This short presentation is about reviewing the Wells criteria in the context of COVID-19 pandemic. Wells criteria for pulmonary embolism is a risk stratification score and clinical decision rule to estimate the probability for acute pulmonary embolism in patients in which history and examination suggests acute pulmonary embolism as a diagnostic possibility. It provides a pretest probability which, if deemed unlikely, can then be used in conjunction with a negative D-dimer to rule out pulmonary embolism, avoiding unnecessary imaging. Wells criteria include clinical symptoms of deep venous thrombosis, 3 points, other diagnosis less likely than pulmonary embolism, 3 points, heart rate more than 100 beats per minute, 1.5 points, immobilization during 3 or more days or surgery in the previous 4 weeks, which is scored 1.5 points. Previous deep venous thrombosis or pulmonary embolism, 1.5 points. Hemoptysis, 1 point, and malignancy, 1 point. According to traditional clinical probability assessment, the likelihood of diagnosing pulmonary embolism is high if the score is more than 6, moderate for the score between 2 and 6, and low if the score is less than 2. According to simplified clinical probability assessment, pulmonary embolism is likely if the score is more than 4 and unlikely if the score is less than 4. Both natural spike protein, meaning SARS-CoV-2 infection or COVID-19, and artificial spike protein, meaning spike protein-based vaccines, may be associated with an increased risk for the development of thromboembolism, including deep venous thrombosis and pulmonary embolism. COVID-19 can be associated with coagulopathy, findings consistent with an infection-induced inflammatory changes as observed in patients with disseminated intravascular coagulopathy. The initial coagulopathy of COVID-19 presents with prominent elevation of D-dimer and fibrinogen degradation products, whereas abnormalities in prothrombin time, partial thromboplastin time, and platelet counts are relatively uncommon in initial presentations. Studies have shown that spike protein alone can damage vascular endothelial cells by downregulating ACE2 and consequently inhibiting mitochondrial function, and that spike-induced degradation of endothelial junction proteins affects endothelial barrier function, which causes vascular damage, all of which together may trigger or cause thromboembolism. A study found that safety profiles of Comirnaty vaccine, meaning Pfizer-BioNTech, and Vaxzevria vaccine, meaning AstraZeneca-Oxford, were similar. A safety signal was seen for venous thromboembolism after first dose of Comirnaty. Although confidence intervals were wider, a similar estimate was seen for first dose of Vaxzevria. There was a 1.3-fold increase in the rate of venous thromboembolism after first dose of Pfizer vaccine, compared with an 8-fold increase after diagnosis of COVID-19. No safety signals were seen for arterial thromboembolism or thrombosis with thrombocytopenia syndrome. I would like to propose that both recent, meaning in the previous 4 weeks, COVID-19 infection and spike protein-based vaccination may be considered to be included in the Wells criteria and scored 1 point for COVID-19 and 0.5 points for recent spike protein-based vaccination in a patient with symptoms typical for pulmonary embolism and/or deep venous thrombosis. Thank you for your attention.